I am your moderator today. My name is Meena Lakshman. I am an applications manager out here. Today's webinar is part one of two-part series on angiogenesis and imaging the microvasculature. Let me introduce our speakers, Dr. Daniela Ardelean and Ms. Melissa Yin. Daniela comes to us as an associate staff in the Division of Pediatric Emergency Medicine at the Hospital for Sick Children. She has very focused interests investigating the mechanisms of pathological angiogenesis and testing vascular-targeted therapies in experimental models. She just received her doctorate, so congratulations, Daniela, from the laboratory of Dr. Michel Letard and was co-supervised by Robert Kerbal. Melissa Yin comes from Dr. Stuart Foster's lab. She's a research biologist at the Sunnybrook Research Institute in Toronto. I have worked very closely with Melissa, and she has her focused interest that includes the use of contrast-enhanced ultrasound and photoacoustic imaging. This is specifically, she uses this to monitor disease progression and therapeutic efficacy. You can see there is a common interest between the two speakers. Without further ado, they will be sharing their findings on targeting the microvasculature with a focus in inflammatory bowel disease. So let's send the platform to you. And here you go, Daniela.
Thank you, Meena. First of all, we'd like to thank the VisualSonics team for this opportunity, great opportunity to share with you and with the audience the result of a fascinating journey in trying to answer to a very specific question. Is an anti-angiogenic therapy capable to decrease chronic inflammation as well as pathological angiogenesis in the experimental model of chronic colitis? And to start with, we have to mention from upfront that this is a teamwork, has been an incredible experience. Teamwork between two amazing labs and investigators, one led by Dr. Michel Letard at SickKids and the other one by Dr. Stuart Foster at the Sunnybrook Research Institute, all under the umbrella of the University of Toronto. The result of this work has been recently published in Angiogenesis, and the title of this paper is shown here. Anti-VEGF therapy reduces intestinal inflammation in Endoglin heterozygous mice subjected to experimental colitis. We'll hope that we'll be able to demonstrate that this is the case. To start with, we'll briefly touch upon on what pathological angiogenesis in chronic inflammatory bowel disease is, the role of endoglin in angiogenesis and inflammation. We'll describe to you the endoglin heterozygous mouse model of chronic colitis, which has very specific attributes, as well as the regimen of VEGF-targeted therapy that we use in this model, and the methods that we employ to be able to measure both colonic inflammation and pathological angiogenesis in this model. Then we'll go over the micro-ultrasound, the molecular intestinal imaging, the abilities of these imaging methodologies to be able to capture two processes, inflammation and angiogenesis, in this endoglin heterozygous mouse model, and conclude. Why is inflammatory bowel disease a very interesting topic to explore and to investigate? First of all, because it's a chronic autoimmune disease which encompasses several subtypes, the most important of which are the following: Crohn's disease and ulcerative colitis. These diseases are characterized by severe gut inflammation associated with systemic inflammation, such as weight loss, fever, and when a gut is so inflamed, as is shown here on the right side, here we have an endoscopic image of an inflamed gut in a patient who has been diagnosed with ulcerative colitis. So inflammation leads to bleeding, weight loss, and fever. It's important to know from the very beginning that both genders are affected, both males and females. And this disease occurs not only in adults, but also in children. And interestingly, as has been recently shown by Molodecki in gastroenterology 2 years ago, the highest incidence and prevalence of inflammatory bowel disease in patients occurs in a developed country. And this geographic map very nicely shows with red the areas that have the highest incidence and prevalence of Crohn's disease on the left side and ulcerative colitis on the right side. And you can see that this disease, the incidence and prevalence in this disease is almost overlaps. So with red we have North America and northern part of the Europe that harbors the high incidence of this disease according to Molodecki and the team. And with light blue, we have the area with the lowest incidence and prevalence of Crohn's disease or ulcerative colitis. Now, intestinal pathological angiogenesis, not only that it's associated and coexists with inflammation, but it's important to know that it's able to enhance inflammation. And before we look into that, into more details, it's important to establish for the very beginning and to remind ourselves what pathological angiogenesis is. It's the new vessel growth from the pre-existent vessels. And when inflammation and pathological angiogenesis persist and feed into each other, it can lead to multiple complications, as it happens in patient inflammatory diseases. They can experience gut perforation, it can lead to strictures, and unrelentless inflammation can lead even cancer in long term. There are traditional and standard therapies that we use in clinical practice, anti-inflammatory medication, biological therapies, but even though these are there are still patients that relapse, that have chronic disease, that do not respond or become resistant to the traditional therapies, and for which the need for novel therapies is more urgent than ever. I mentioned briefly that inflammation and angiogenesis are two codependent fundamental biological processes, and the best example that one can think of is to think of the wound healing. When there is an injury, the immediate response from the tissue that it's affected is to produce inflammation and to produce new vessels grow. On the left panel, you see that this process take over and is driven further and peaks somewhere at day 7 to 9 after the injury. Normally, however, after the need of the tissue are accomplished and the wound healing happens, both inflammation and angiogenesis should resolve. This is the resolution process. However, there are diseases both in oncology and in cancer model, as well in the chronic inflammatory diseases. And I'll mention up front that also it happens in vascular dysplastic disorder, for example. When inflammation and angiogenesis persist, they do not regress, they do not resolve. When this happens, it leads to pathological angiogenesis and a disease state. We all know that one of the major angiogenic factors that plays a key role in angiogenesis is vascular endothelial growth factor, in short, VEGF. There are multiple isoforms that belong to this class, which signal through various receptor and co-receptor, the most important of which are two, VEGF receptor 2 and VEGF receptor 1. And the role played of VEGF in angiogenesis is demonstrated by many studies that have been proven for the last 40 years or so, that these factors is important in endothelial cell migration, vascular permeability, survival, endothelial cell proliferation, all hallmarkers of new vessel growth. Why endoglin? Endoglin plays a major role, or a very interesting role in angiogenesis, and also, we believe, plays a role in inflammation. It's well recognized that endoglin is present on quiescent vascular endothelium, and is highly upregulated on activated vessel in tumors, and interestingly enough, also in chronic inflammatory disorders, as has been shown in the study that are referred here to. In the last 4 or 5 years, there have been successful attempts in preclinical tumor models of breast cancer and lung cancer of, using antibodies against endoglin. That has been shown that by doing so, by targeting endoglin, one, we might be able to contain and even to decrease the frequency of metastatic disease in these preclinical tumor models. And I think the most clear example why endoglin plays such a significant role in angiogenesis is demonstrated by the fact that when one target and deletes endoglin in mice, these mice died in mid-gestation and embryonic day 10.5 because they developed severe cardiovascular and angiogenic defect. And I mentioned briefly that even though there is not much known about the role of endoglin in inflammation, what we do know is that endoglin is also present on the surface of activated monocytes or macrophages, therefore might play a role in inflammation, and also is present on the vascular smooth muscle cells and fibroblasts, therefore plays an important role in tissue remodeling, which occurs both in inflammation as well as in angiogenesis. What is endoglin? Endoglin is a co-receptor for the TGF-beta superfamily of ligands, which in this case, the one that are of interest for this study is TGF-beta and BMP9 on the right side. TGF-beta, when it signals, binds first to its receptor, TGF-beta receptor 2, which in turn activates this co-receptor called endoglin, and also is able to activate the TGF-beta receptor 1 called ALK5 on the left side, leading to activation and phosphorylation of an intracytoplasmic type of protein called SMAD2/3, and further to specific activation of certain transcription genes. On the other hand, endoglin is also able to bind directly BMP9, who also activates ALK1, another very interesting, almost exclusively expressed endothelial receptor called ALK1, through which the signaling further progress downwards towards activation of SMAD158 and then further modulation of other specific transcription genes, leading in the end to modulation or fine modulation of angiogenesis. It's important to know that these arms of this very complex system also interacts to each other at various levels, leading to activation of other pathways, some of which are shared with the VEGF signaling. Now, we are fortunate to be able to use a very interesting mouse model, the endoglin heterozygous mouse model of chronic colitis, developed in Dr. Michel Letard's lab a few years back. And what's interesting about this model is that when one uses one single course, and I'm going to repeat one more time, it's one single course of dextran sodium sulfate in a concentration of 3%, given daily in the water for 5 days, it's able to induce severe intestinal inflammation and abnormal vascular protrusion in the heterozygous mice, whereas in the wild-type mice, both inflammation and vascular protrusion resolve, processes that are associated with high VEGF levels. Therefore, we hypothesize that if we target VEGF, we might be able to decrease this abnormal vasculature and also perhaps to reduce the intestinal inflammation. And to do so, we are very fortunate to be able to, to use a very interesting antibody called G631, a monoclonal antibody with high affinity for murine and human VEGF-A, who is able to neutralize all isoform or VEGF-A. This was provided by Genentech. And it's interesting to know that the clearance is similar with bemacizumab, which is a human monoclonal antibody which has been used for the last few years or so in patients with metastatic cancer disease refractory to traditional therapies. So after optimization, we decided to pursue it as follows. We used 5 milligrams per kilogram per dose of this of G631 monoclonal antibody, which was injected intraperitoneally 3 times, started at day 9, and we specifically choose day 9 as the starting point because in our model this was the time when both inflammation and angiogenesis where there are peaks. So one at day 9, followed every 5 days afterwards by the second injection, which was given on day 14, and the third one given on day 19 of disease. Afterwards, we analyzed the mice at day 20 to 25, and we decided to look in the following parameters. One, to look into the in vivo by using ultrasound at both inflammation and pathological angiogenesis, and we'll share with you further how we've done that. To use histology to look at inflammation as well as pathological angiogenesis by trying to quantify the CD31 stained vessels. And also we look in the tissue and plasma, and we measure several factors which were of interest for us. Angiogenic, angiostatic factors, some chemokine, and pro-inflammatory markers. As I mentioned before, it was a tremendous importance to be able to look in vivo at pathological angiogenesis and inflammation. And we are very fortunate, indeed very fortunate, to be able to work with an amazing team led by Dr. Stuart Forster Sunnybrook. And my friend Melissa, my friend and colleague Melissa, is going to go over some of the details of the equipment that we use, software, and so forth. Melissa?
Thank you, Daniela, for the introduction. So I think when you first approached us with this, really, looking for an alternative method to measuring and looking at some of these in vivo changes in the animal model without using, one of the conventional methods, which usually involves histological analysis or ex vivo analysis of the tissue. So we were really looking for a method, a more non-invasive platform for us to look at these changes that would occur. In our case, our imaging platform interest was preclinical micro-ultrasound, which itself have a number of advantages. So as I mentioned, first of all, it is non-invasive. It allows for real-time imaging. And I think one of the biggest advantages is it allows for you to longitudinally monitor these changes that occur in your animal model in vivo. So what this means is instead of needing to sacrifice your animal at different time points to extract your tissue and to look at, to do postmortem analysis, you can now, in the same animal at different time points, monitor your changes. So number one, it can help you decrease the number of animals needed for your analysis, and also in some ways you can almost decrease your animal-to-animal variation because you are looking at these changes within the same animal. Like I mentioned, there's no longer the necessity to sacrifice your animals for your tissue. And then in terms of really looking at the data and some of the changes, with ultrasound you can look at both anatomical changes and functional changes that happen in your tissue. And if you wanted to dig a little deeper, there is also the opportunity to look at molecular changes inside your cells or cellular pathways. The imaging data collection time with ultrasound is quite reasonable. With our previous experiences, one animal will generally take from 15 to 30 minutes to image. And lastly, ultrasound really offers high temporal resolution. So what really that means is the resolution is quite high with respect to time. So when we're talking about preclinical ultrasound, there is a number of different imaging modes that's involved that can allow you to focus on different areas of tissue changes. And I think when I mention ultrasound, what comes to mind for a lot of the audience is beam-mode imaging, which is your basic grayscale imaging. So it is a two-dimensional ultrasound image display that's composed of bright dots representing the ultrasound echoes. So the brightness of each dot is determined by the amplitude or the strength of your return echo signal. And when we look at BMO images, what we're really looking for a lot of times is the visualization or the quantification of anatomical structures or morphological changes. Now, if we wanted to go further and looked at functional changes, there is options such as contrast mode imaging, which utilizes contrast agents that help increase the signal in the blood compared to the surrounding tissue. It can be used to look at hemodynamic changes in your tissue region of interest, and like I mentioned, it can also be used to target specific receptors of interest for molecular imaging. There is also the option of Doppler imaging, which is also used for the spatial profiling of the vasculature inside the tissue. The advantage of Doppler imaging a lot of times is it's really good for a quick evaluation of vascular changes, and its strength is at detecting fast flow and big vessels. And lastly, when it comes to the focus of cardiac research, there is M-mode imaging, which is very high temporal resolution imaging that uses one single ultrasound beam. It can allow you to look at the movement of the myocardium or vessel walls, but I think really for the focus of our project and what we're going to be talking about today, we're going to focus on the top two, which is B mode and contrast mode imaging, which we'll use to kind of help us evaluate a lot of these changes that we see in our colitic disease model and our treatment model.
Thank you, Melissa. In order to do so, we use the Vevo 2100 platform, and you can see on the lower quadrant, the setting of this experiment. This is an anesthetized mouse, and Melissa will describe further, if there is interest, how we've done that. But more importantly, we looked at three major parameters. One, the colonic wall thickness, which will give us an estimate of the inflammation impact on heterozygous colitic mice, and as well as the response to treatment in these mice. Secondly, we wanted to look at the microvascular hemodynamic by measuring two very interesting and important parameters. One is the blood flow rate, how fast the blood moves through the inflamed vessels. And secondly, the blood volume, which is the in vivo surrogate for the microvessel density that traditionally is used in preclinical tumor models and to assess pathological angiogenesis. And thirdly, very important, to look at the binding, how much binding of a targeted microbubble, which bears MADCAM antibody on its surface, occurs at the level of the surface of the inflamed microvessels in these mice, and what is the response of these MADCAM-positive intestinal microvessels to the targeted anti-VEGF antibody. And very briefly, what MADCAM stands for, this is a mucosal adenosine cell surface marker that is highly upregulated specifically at the site of intestinal inflammation. This is why we chose it specifically to be able to assess the response of inflamed vessels in the affected colon in our mouse model.
Okay, well, thank you, Daniela. As Daniela has just mentioned, most of our in vivo ultrasound experiments are broken into three major portions, and I will elaborate on each in the following slides. So we really began with looking at anatomical changes using B mode imaging. And so anatomically, what we're focused on looking at is changes in the wall thickness with respect to inflamed colon and compared to a normal non-diseased wild-type colon. So if you focus your attention to your image on the right side of your screen, it is a sample image of our experimental setup. So just so you get an idea of what our ultrasound setup looks like. So first of all, you have your anesthetized mice, which is lying on a heated imaging platform. The heated imaging platform allows us to keep our animal at a 37 degrees Celsius monitored body temperature. So what you want to focus on is our imaging ultrasound probe. It is actually placed in parallel to on the longitudinal axis to the animal. right on top of actually the distal colon, which is our region of interest that we wanted to focus on. So if you wanted to have a quick idea of where we're looking exactly in terms of the large intestine, the distal colon is at the end of your large intestine. It is the relatively straight region. It's around 4 centimeters in length, and that's the region that we're looking at. So with our ultrasound, we're imaging with ultrasound. We generate ultrasound image that's you can see in your left-hand screen. It is a representative image of what we generally look at. So there is a little tip that comes with kind of generating these images. There's a lot of optimizations that does go in for, the interest of looking at the distal colon. You can see that in the image, you can see very clear delineation between the lumen of the colon and the upper and lower walls of the colon. So to achieve this, we actually injected a small and even amount of sterile ultrasound gel into the distal colon. And the reason for this is by injecting the gel, what it does is it kind of gets rid of some of the gas and fecal matters that is in the region and gives you that really clear contrast between the lumen and the wall. So when we're looking at our colon wall thickness measurements, what we do is we actually collect a 3D volume image. So what happens is, with the sample image we show you, is we take a external 3D motor and we actually image across the width of the colon at a step size of around 50 micrometers. And then so what that does is, within our 3D volume, we're actually covering all of the distal colon. And from a number of images, around 100 images that we do collect, we select 4. And these 4 image slices gives us a kind of a good distribution of what we're looking at from one side of the colon to the other, and we try and select images that really gives that clear delineation of the wall. And then we take the measurements from both the top of the wall and the bottom, 10 measurements each, and from these 20 measurements, we get the average wall colon thickness, which is our quantitative value that we use for comparison with each of our animal groups. Which then brings us to our next slide, and the bottom left corner is the ultrasound wall thickness measurements quantitative value summarized in your bar graph. So if you look at the top, there's 3 images, which represents the 3 groups of mice that we imaged. I'd like to mention right now that for all of our ultrasound experiments, we imaged 3 groups of animals. So there is the wild-type group, which is treated with PBS, represented in white. In the middle, there is our heterozygous endoglin mice that was treated with PBS, which I'm going to call our disease group from here on. And lastly, they're represented in red. There is our heterozygous endoglin mice that was treated with our anti-VEGF treatment, which I'm going to call our treated group. These terms might be used interchangeably, but so if you just take a look at the images right now, it is quite obvious to see, if you focus on where the red arrows are pointing, that the wall thickness that you can see within the BMO images in your disease group is visually even thicker in comparison to your wild-type group and your treated group. And if you look at our standardized quantitative value in our bar graph in the bottom left corner, so the y-axis is wall thickness in millimeters, you can see that within the disease group, we saw a lot an increase in wall thickness in comparison to wild-type group, and after the treatment was given, we actually was able to observe a decrease, so the wall thickness did go back down with our treated group. And so I just wanted to mention that in each of our groups we used an N of 9 to 12 animals. The standard error the error bars you're looking at right now is your standard error of mean, and the differences that you see here are all statistically significant.
And in order to confirm this finding that were presented right now by Melissa, we also looked into histopathology. So we are very fortunate to work with an expert pathologist at the Hospital for Sick Children, Dr. Bonian, who used a composite inflammatory score which included several parameters, from which I'm going to briefly discuss only about mucosal thickness score. So here you can see clearly that there is almost a threefold increase in the mucosal thickness score in the colitic Endoglin heterozygous mice when we compare with the wild-type group. And very importantly, after treatment, this mucosal thickness score significantly is decreased after the use of anti-VEGF treatment. And why is it important? Not only that it confirms the in vivo finding by ultrasound, but we are able to validate it in a way bidirectionally the fact that both methodology can be used, but of course it's a huge advantage to be able to use a non-invasive in vivo method which accurately is able to measure, to quantify the wall thickness, which is one of the parameters of importance in the chronic inflammatory diseases.
Okay, and I think that brings us to our second portion of our interest. I'm going to wait for a little bit for the video to load while I kind of explain to you the basics of contrast-enhanced ultrasound, which we use to kind of help us evaluate some of these hemodynamic changes. So if you look at your image on your left side of your screen, you can see that it is a dark field microscopy image of both red blood cells and microbubbles. So microbubbles is the ultrasound contrast agents that we use, and you can see from the image that they are, their size is very comparable to red blood cells. So what this means is, they go basically wherever red blood cells go, and they don't go wherever red blood cells don't go. So they can go to as low as capillary levels, looking at microvasculature, but at the same time, they are kept strictly in the vascular circulation of the animal. So to administer microbubbles right now, via a tail vein of the animal, and then as the microbubbles are injected and circulates around the circulation of the animal, we image our region of interest and so that is sample that if I can help you make it out, does it always bounce like that? Okay. So we'll come back to other videos, but just a little more details on what microbubbles are. They are basically gas bubbles, and so the gas usually is either air or perfluorocarbon. In our case, we use the Vevo micromarker, which is produced by Bracco, and they do use perfluorocarbon as a gas. And these microbubbles are around the size in the micro range size, so they're around 1 to 10 micrometers in diameter. They are encapsulated inside a shell to make sure, to stabilize it and make sure that the gas does stay in. So the shell can be either made of protein or phospholipid. In our case, our microbubbles that we use were made of phospholipid. And I think now we're going into a little some of our specific imaging parameters. So on your left-hand side, I provide you with some of our imaging parameters that we use within our ultrasound system. I think the one thing I wanted to point out that we did use the MS-250 probe, which runs at a center frequency of 18 megahertz. So that is one of the non-linear ultrasound probes that can be used on the Vevo system. But in short, we inject our Vevo microbubbles in a bolus volume of 50 microliters through the tail vein, and looking at our image region of interest, which is the distal colon. It is given in a bolus form, but to make sure that our bolus is given the same way each time. We use the injection pump and inject it at a rate of 600 microliters per minute. The average concentration of your microbubbles when you get the vial, when you get the vial, it is a freeze powder which you have to reconstitute. So once it's reconstituted, you'll get a average concentration of 2 times 10 to the power 9 microbubbles per milliliter. And remember, you're injecting a 50 microliter volume each time. So just keep in mind, all these parameters that you see on the left side, which is your ultrasound imaging parameters, they are kept the same throughout our imaging studies, just to make sure when we're quantifying our values, they are comparable. Next, I think I'm going to bring your attention to basically what we were looking at when we were injecting these microbubbles and looking at their wash-in into the colon. So if you just focus your attention to the static image on your right side, the image you're looking at is a contrast image of the distal colon. So the right circle that you see, the green circle is highlighting the upper layer of the colon wall, whereas the yellow is highlighting the lower colon wall. And you can, the video is loading. Okay, so now if you look at the video, and it's playing right now, once the microbubble is injected, let's just play it again. You can see the microbubbles wash in, and there's an increase in the signal that you see. And if you focus attention to the regions that we selected on beside it, you can see that most of the bubbles are washing into the colon wall, where a lot of the vessels are surrounding the tissue. But from these videos, what we generate is this time intensity curve that you see on the bottom. For each region area of interest that's selected, you get this time intensity curve. So on the y-axis, you're looking at your averaged echo that you see within your contrast images, whereas you're seeing the change that occurs over time. So you'll see that initial increase in signal as your microbubbles are washing into your region, and then that signal will plateau, and if you give it long enough, it will clear out. So we're really right now just looking at the first 22 seconds of the image, and we're interested in looking in the washing of these microbubbles. But from these time intensity curves, you can generate a number of parameters that you can quantify. In our case, we look specifically at 2. There is the wash-in rate, which is your steepest tangent of your curve. And what that is it's used as an indicator of the rate of blood flow inside your tissue region of interest. We also looked at peak enhancement, which is your maximum amplitude minus the baseline signal that you get. And what that is used as is an indicator of relative blood volume within your tissue region. So the reason that we specifically chose these 2 parameters because we do understand in the disease models when colitis is taking place, there is an increase in the number of pathological angiogenesis, and because of that, we do expect these 2 parameters to change. When we looked at all of our groups of animals and we took all of our data and averaged it, what it looks like is this average time intensity curve here. So again, I just wanted to remind you that white represents the wild-type group, blue represents the diseased treated group, and the red represents the diseased-treated group that's treated with the anti-VEGF treatment. On your y-axis, which is kind of a little bit folded up, but it is your contrast mean power that we're observing in each of the animals, and your x-axis is time. So I think really the take-home message that I want you to take home right now is if you look at the curve that is in white, you compare it to your disease group, you can see with the peak enhancement parameter, there's definitely a big increase, and the curve and the slope of the curve in the disease group is much steeper in comparison to the wild type. And the most important part is with anti-VEGF treatment, we were able to see that decrease, and it's almost like the 2 curves overlap between the wild type and the treated. The images on your right-hand side just is a color map image that kind of shows you a little more of the distribution of the blood volume within our colon walls. So the color scale that you're looking at right now is red for areas of high blood perfusion, with blue being areas of low blood perfusion. So as expected, with the disease group, we see a lot more of the red and the yellow representing there's a lot of blood in the region. This compared to the wild type and the treated group, where you see a lot more of the green and the blue representing lower perfusion. Just kind of gives us a further idea that what we're seeing is increased angiogenesis or perfusion inside tissue. As I mentioned, there's two parameters that we quantified, and when we quantified all these values and put it into these bar graphs, you can see it. So on your left-hand side, it is peak enhancement on your left-hand side, which again is an indicator of the relative blood volume within your tissue. And on your left-hand side is the washing rate, which is an indicator of the rate of blood flow. So you can see side by side these two, other than the scale that you see on the y-axis, these two graphs looks actually very similar to one another. But I think the take-home message again is that we were able to observe that increase in both the blood volume and the rate of blood flow in the disease groups, whereas it is statistically significantly larger compared to the wild type, and with the treatment given, both of these values were brought back down. Just for your interest, each group has a N of equaling to 5 to 7. And yeah.
To confirm this in vivo data, we also look at the microvessel vascular density in the inflamed gut in the three groups that Melissa was mentioning about. And what we use here, we use the CD31 positive microvessel staining, which are depicted here with brown color. And you see in these representative images, for example, for the heterozygous colitic mouse, that there are more brown spots, therefore more vessels and inflamed gut when one compares with the wild-type representative mouse. And more importantly, on the right-hand side, there is a reduction in the numbers of these CD31 positive microvessels in the inflamed gut of the mouse which was treated with anti-VEGF therapy. And the quantification very clearly shows on the same pattern that we've seen with in vivo imaging, with the ultrasound imaging technique that we looked before. It was blood flow rate and blood flow volume. Here, we look at microvessel density, and we show clearly that there is almost a threefold increase in the number of microvessels in the heterozygous colitis group compared with the wild-type group. And very important, when one is treated with a G631 monoclonal antibody, this microvessel density significantly is decreased, which proves that there is a reduction in the pathological angiogenesis, as is assessed here more traditionally in vitro as a result of this anti-angiogenic therapy.
Okay, so after looking at our hemodynamic changes with our non-targeted contrast, we wanted to dig a little deeper and see if there are any cell surface biomarkers that is of interest that we can look at using targeted microbubbles. And just before we go into some of our results, I want to give you a little bit of background in terms of how targeted microbubbles work. So with targeted microbubbles, what you do start off with it's very similar to our non-targeted microbubbles. So you have a perfluorocarbon gas core that is encapsulated into a phospholipid shell. Now the difference here is within the shell there is strip avidin incorporated. What this means is this allows you to attach biotinylated antibodies of your interest onto these microbubbles via the strip avidin biotin interaction. So you're conjugating targets that you're interested in looking at onto these microbubbles, thereby making them targetable. So for people that do immunohistochemistry, if there are antibodies that you are using right now that are cell surface biomarkers that you're interested in, if you can find them, if they're commercially available, and you can find these antibodies to be biotinylated, you can sort of create these targeted microbubbles of your own and try them out. So just to give you some examples, for example, for thrombus, there is the glycoprotein 2B38 that you can look at as a target, or in angiogenesis, people have looked at VEGF-R2 or alpha V beta 3 integrin, or atherosclerosis, there is ICAM1 and VCAM1. So target microbubbles do allow you to characterize biological process at the cellular and molecular level. But one thing you need to keep in mind that, as I mentioned, because the size of these microbubbles, they are limited to the vasculature, which means most of the targets that you can target are likely endothelial cell surface markers. I think for the sake of time, I'm just going to skip the next slide. It just gives you a number of advantages why we should be using targeted ultrasound microbubbles. But which brings us back to our project, where we kind of looked at targeting MAD-CAM as our target of interest. Before we kind of go into what data we were looking at, the way targeted microbubbles work is there is an imaging protocol that is involved, where you start off by injecting your bolus of targeted microbubbles, and what will happen is you'll image for the first 30 seconds, at least, where you're watching these microbubbles flow into the animal, circulate around. What you're observing at the first 30 seconds is these free-flowing microbubbles, and that creates that time intensity curve kind of shape that you see before. And from this data, you can extract parameters such as washing rate or peak enhancement. Now then, there is a time period that you do need to wait for the microbubbles to bind while they're circulating inside the animals. In our case, we use 2 minutes. And what happens is during that time, these microbubbles will be able to bind. And when you're imaging again after that 2 minutes, the signal that you're going to see is a combination of the remaining free circulating microbubbles and bound microbubbles. So the pre-destruction signal that you're getting is a combination of the two. Now, right after imaging for another 15 seconds to get that signal, we do send a high-power destruction sequence. What it does is it collapses all the microbubbles that is in your imaging plane of interest, and so then what the microbubbles that comes back are only the free-flowing microbubbles. So then this becomes our post-destruction signal. And by taking the difference between your pre-destruction signal and your post-destruction signal, you're able to get this parameter called the differential targeted enhancement, or basically the differences between your signal you get before destruction and after destruction, which is the representation of the number of bound bubbles that you saw in terms of ultrasound signal, or the binding of your microbubbles to your targeted molecule. So when we're looking at this specific parameters for our project and targeting MAD-CAM, now the y-axis here is the differential targeted enhancement, or the number of bubbles that we think is binding according to this ultrasound signal that we see. And again, there's our 3 groups, the white being the wild type, the diseased in the blue, and the treated in the red. And what we can see is that there was the signal that we got from our disease group was a lot higher in comparison to the wild type and the treated group, which, according to what I just explained, does translate to that we're getting a lot more binding of these targeted microbubbles to the disease group, which is expected, as we would hypothesize that there is increased expression of MAD-CAM in the colitic colon. And I just wanted to point out again that this difference between the groups is statistically relevant.
Also, we look at the levels of VEGF in the plasma, in the tissue, in the 3 groups. And you see here in the left-hand side, the wild type, the heterozygous PBS-treated group, and the G631-treated group. And an additional group called immunodepleted, because we use a technique to look at what are the residual levels of VEGF that are left both in the plasma as well in the inflamed tissue after one removed the complex VEGF to its anti-VEGF antibody. And clearly you see a few points here. One, that in this study, there was no difference in the tissue VEGF levels between the wild type and heterozygous PBS-treated group. which we explain and we confirm actually through 2 additional methods, Western blot and multiplex ELISA. And we explain by the fact that these mice were harbored in a different facility, their health status, and also the difference in the sensitivity of the assay used in this study and the previous one. Thirdly, day 1 to 5 after the 3rd injection, we can clearly demonstrate that there is a 50-fold increase in the level of the total VEGF, defined as the VEGF that is bound to its complex anti-VEGF antibody in the circulating plasma of these treated mice. And in the colon, the level remains similar with what has been shown before. And there is an explanation for that. You have to remember that VEGF is present not only in the endothelium, but also in the surrounding parenchyma. It's produced by immune-activated cells, and importantly, also by intestinal epithelial cells. So there is an ongoing dynamic process of production and destruction of the tissues and ongoing inflammation. And lastly, very important, there is a 40% decrease in the level of VEGF after we removed, in the residual VEGF, after we removed the complex VEGF to its antibody. And why is this important? Because even though VEGF doesn't seem to play a major role in the pathogenesis of inflammation and angiogenesis in our Endoglin heterozygous mouse model of chronic colitis, when you target it, this decrease in the tissue VEGF level is associated with decreased tissue inflammation and pathological angiogenesis. And we believe and we think that the explanation of these beneficial effects of an anti-angiogenic therapy and an experimental model of chronic colitis is the fact that this therapy somehow is able to restore the tissue angiogenic balance, which leads to beneficial effects. And we suggest that perhaps anti-VEGF therapy might also have a direct anti-inflammatory effect, which would be important to consider in both in the preclinical tumor model as well as chronic inflammatory diseases. We hope that we are able to demonstrate that in vivo ultrasound imaging results were validated by immunohistochemistry methods, and to show you and to share with you the advantages with using a non-invasive method to look not only at disease progression, but also at the effect of the therapy in a mouse model of chronic colitis. As we've shown, ultrasound is an accurate non-invasive method to quantify and monitor the intestinal microvascular hemodynamic and inflammatory changes, and also to assess the effect of this therapy in experimental inflammatory models. We want to acknowledge that this was definitely to the teamwork. It was a very fun and rewarding journey between 2 labs, Dr. Michel Letar's lab. We have to highlight the contribution of Dr. Mirjana Djurkic, Madonna Peter, as well as between Dr. Stuart Foster's lab. The very important role of our expert pathology from SickKids, Dr. Bonian, the very important role of the anti-angiogenic expert, Dr. Robert Kerbel from the Sunnybrook Research Institute, and the very important contribution of Lily Morikawa and Napoleon Lau from Toronto Center of Phenogenomics. And also, of course, the funding agencies, organization, and institution. Without this project could not happen. CIHR, Canadian Association of Gastroenterology, SickKids Hospital, the Ministry of Health, the Postgraduate Medical Education Department, the Clinician Investigator Program from University of Toronto, and the Department of Immunology of University of Toronto. We thank all of them. And we thank you for your attention, and we are more than happy to take your questions now.
Thank you, Daniela and Melissa. This was very exciting. We can take a few questions as it comes through. There's one question with respect to technical before we close off. How much gel did you have to use to get those beautiful pictures non-invasively? Melissa?
So there's like two key things you have to think about when you're injecting. First of all, the needle we use isn't your conventional needle. We actually use a gavage needle that was straightened. The reason for that is there is a blunt end to the gavage needle. You don't want to damage any structures when you're entering the tissue. I think the approximate volume that we injected for the 4-centimeter region that we're looking at is around probably 400 microliters, 400 to 500 microliters. So that's around about 100 microliters per centimeter of volume. Really, it is by user because you are injecting the ultrasound gel. So you want to make sure you're injecting lightly, and it's user-based. So it's something to optimize and work around, and it really depends on your model.
Well, you have now, you know two experts that can provide you advice. We look forward to your questions, and feel free to connect with us. We just would like to thank the speakers for bringing the link between signaling, using genotypic expression, and we also like to thank you guys for bringing that link from mouse to molecular mechanism to postmortem analysis and showing the trend and agreement between all three. We would like to take one more question. Besides the volume of gel, we want to know if there was any consideration of report of additive negative interplay between VEGF and endoglin in models of preeclampsia. Endoglin is known to play a role in preeclampsia. I think this is a question that will require a little bit more of a discussion, and I will forward this question to Daniela, and we'll follow up with you if that's okay. All right. In closing, we'd like to bring you with an imaging update on colonic health. There was a recent publication. Here you're looking at a cross-section of the colon, and there was a recent publication showing molecular oxygenation within the colon, as you can see in red color out here. This was done by photoacoustic imaging on the Vevo laser. And the publication is right here for you, just in case those of you who are interested. For those who are continually coming up with questions with regards to commercial microbubbles that are available, do you make your own? Well, we have our micro marker that's sold by VisualSonics that you can use. This was used in your study, correct, Melissa?
So Vevo micromarker was our microbubbles that we used. There are also other commercially sold microbubbles. So Definity is used in the clinic a lot, and I know all labs do their in-house microbubbles through sonication and other methods. So there are ways. But in our case, we did use a commercially available microbubble.
Wonderful, thank you. All right, next steps. For those of you who are interested where we go with this, today we did talk about ultrasound imaging using the Vevo 2100. That was the imaging mode, the analysis package, and the contrast markers that were used are recapped out here on this slide. You can also get to know a lot more information at VisualSonics.com, or can send us an email. I would like to remind you that the next part 2 of this webinar series is imaging the microvasculature, but we'll be focusing on the challenges presented in cancer progression. Also, you can visit us, you can meet us at American Association of Cancer Research that's held next month, April 6th to 9th. We are at booth 1627 in San Diego. If you are attending, we will also be attending experimental biology conference next month as well. As always, we're all trained scientists. We'd like to share our research, make use of the platform today, and send us your abstract if you're interested in sharing your research and qualify to become a Vevo Ambassador. At this point, Melissa and Daniela, I'd like to extend the invitation to join the Vevo Ambassador community. And thank you so much for taking the time to share your research findings and educating us on endoglin, non-invasive ultrasound imaging, molecular ultrasound imaging, and how this ties to chronic inflammation. Thank you.
Our pleasure. Thank you.
Thank you, everybody, and we hope to see more of you and learn from you all. Until next time, bye-bye.